Welcome to our guide on the EU MDR provision relating to state-of-the-art. In the light of the new EU regulations, authorized representatives, auditors and regulatory authorities regularly discuss what the state-of-the-art is with medical device manufacturers. Manufacturers face potential delays to authorizations, unnecessary redesigns of devices, and costly clinical investigations or, for in vitro diagnostic devices, clinical performance studies. Therefore, the purpose of this module is to try to summarize the current status and identify what manufacturers can do at a practical level to comply with this requirement. So, why it's difficult to pin down exactly what is meant by the term state-of-the-art? According to the MDR, all manufacturers are required to be committed to meeting the regulatory requirements and developing devices according to the state-of-the-art. Unfortunately, there are a lot of hurdles in their way, and little consensus as to what this involves. Manufacturers must develop their devices considering the state-of-the-art. Unfortunately, manufacturers are pretty much left to their own devices when it comes to the question of what this means and how it is defined. Let us look at some of the main issues around the problem. It seems there will be no harmonized standards for the MDR or IVDR for the foreseeable future. In the past, harmonized standards formed a good consensus between manufacturers on one side and authorities or notified bodies on the other. Although the regulations use the term state-of-the-art over 20 times and require that it is implemented, they do not define what the term actually means. Anyone hoping to find clarity in other sources will also end up with additional questions. As if the absence of a definition wasn't bad enough, the regulations also contain different versions of the term. You will also find references to the latest state-of-the-art, the generally acknowledged state-of-the-art, the current state-of-the-art, and in some cases, state of the science. Even those who think they can differentiate between the variations in terminology probably feel overwhelmed if they try to compare the different language versions of the regulations. For example, the English version of the Clinical Evaluation Plan requires taking into account the state-of-the-art. And the Performance Evaluation Plan for IVDs must contain a description of the state-of-the-art. However, in the German versions of the MDR and IVDR, the corresponding parts of the text state that the latest state-of-the-art has to be taken into account. The German version also demands the latest state of knowledge and the latest state of medical knowledge, whereas the English version always refers simply to the state-of-the-art. These discrepancies are not isolated cases. Even when expressly asked, notified bodies are reluctant or are even not allowed to make a clear statement on whether manufacturers should reference standards when having their devices authorized, and, if so, which standards and versions should they reference. Such as standards harmonized under the directives, standards planned for harmonization under the MDR or IVDR, or the latest version of the standards. So, let's look at what we do know. Whilst there is no universally accepted and industry-independent definition of the term, but we can look at how they might be applied to medical devices and IVDs. The third edition of ISO 14971 adds the missing definition of the term state-of-the-art, i.e., developed stage of technical capability at a given time, as regards products, processes, and services based on the relevant consolidated findings of science, technology and experience. The standard adds the following note to this definition. The state-of-the-art embodies what is currently and generally accepted as good practice in technology and medicine. The state-of-the-art does not necessarily imply the most technologically advanced solution. The state-of-the-art described here is sometimes referred to as the generally acknowledged state-of-the-art. This note is very helpful for manufacturers. Manufacturers can equate the state-of-the-art and the generally acknowledged state-of-the-art, and thus avoid unnecessary discussions about the differences between the two. The most technically advanced solution is not explicitly demanded. Looking at the phases in the development of products and technologies, we can see that in most cases products are marketed, refined, and withdrawn from the market at the end of the product life cycle. According to ISO 14971, the state-of-the-art is the generally accepted good practice in technology and medicine and not necessarily to the most technically advanced solution. The most technically advanced solution is the one that marks the boundary between the state of science and the state of the art. Whether the MDR and IVDR are referring to this boundary when they talk about the latest state of the art is not clear. Medical devices and IVDs must comply with the state of the art, not the state of the science. Let's take computer security as a practical example. State of the science might refer to quantum cryptography, which is still in its infancy, in terms of development and research. State of the art would equate to current guidance on password strength, for example. And obsolete would include WEP encryption of local area networks. The regulations attempt to ensure that the devices provide the highest level of benefits and safety. Newer devices often offer greater benefits. Since their technologies are not as tried and tested, the benefit-risk ratio is not necessarily better. This is the line that the regulations are trying to get manufacturers to assess. The regulations also aim to ensure that the requirements for the devices are not so high that manufacturers can no longer economically viably comply with them. Since devices, with an excellent benefit-risk ratio, but never reach the market, do not provide any benefits at all. Whether the authors of the regulations see this second aspect as an aim sometimes seems questionable. So, how can you ensure that you are assessing whether your product is state-of-the-art, and equally important, how can you evidence this to the notified body, authorized representative or regulatory authority? The MDR and the IVDR demand the state-of-the-art in the following areas, among others. Definition of the performance requirements. Determination of the benefit-risk ratio and risk acceptance. Selection of risk-minimizing measures. Software development. Planning and conduct of clinical evaluations, or performance evaluations of IVDs. And performance of clinical investigations. And specifically, for IVDRs. Planning of post-market performance follow-up. And scientific advice from EU reference laboratories. A very similar set of requirements are detailed in the Guideline for Clinical Evaluations, MEDEV 2.71 Revision 4. This also requires manufacturers to determine the state-of-the-art and take it into account when defining the benefit-risk ratio, updating the clinical evaluation, determining the clinical performance and the clinical safety profile, and carrying out the literature search. Benefits and risks should be specified, e.g., as to their nature, probability, extent, duration and frequency. Core issues are the proper determination of the benefit or risk profile in the intended target groups and medical indications, and the demonstration of acceptability of that profile based on current knowledge, or the state of the art in the medical fields concerned. When updating the clinical evaluation, the evaluators should verify compatibility with a high level of protection of health and safety are acceptable according to current knowledge, or the state of the art. Sufficient detail of the clinical background is needed so that the state-of-the-art can be accurately characterized in terms of clinical performance and clinical safety profile. A summary and justification of the literature search strategy applied for retrieval of information on current knowledge or the state-of-the-art, including sources used, such as the search questions, search terms, selection criteria applied to the output of the search, quality control measures, results, number and type of literature found to be pertinent, and the appraisal criteria that were used. As a first step, we can try to define the state of the art. Manufacturers are required to document the results of this analysis in the clinical evaluation or performance evaluation for IVDs. This documentation must also describe how they carried out this analysis. Manufacturers should consider the key questions they can use to determine the state of the art. These key questions can be divided into two groups. The first group are alternatives, for example. What are the alternative devices, e.g., predecessor devices and competing devices? For IVDs, are reference methods available and, if so, what are they? Do alternative device categories exist? For example, MRI instead of CT scans. Are there any alternative procedures, or in the case of IVDs, alternative diagnosis options? For example, chemotherapy instead of radiotherapy. What alternative materials and technologies are available? What are the alternatives in terms of other device designs? Are there any other production processes? The second group relates to a comparison of the alternatives identified. How do these alternatives compare in terms of clinical benefit? For example, sensitivity and specificity of a diagnosis, number of days in the hospital, percentage of cured patients, reduction of the pain level on a 10-step scale, possibility of diagnosing different clinical subpopulations. How do these alternatives compare in terms of performance? For example, a lifetime of an implant, accuracy of the RF pulse generation, number of possible reprocessing cycles, resolution of an imaging procedure, limit of detection of a diagnostic analysis method, time until the diagnosis is available. How do these alternatives compare in terms of safety? For example, mean time between failure, protection against incorrect entries and other use errors, probability of air bubbles being detected in an infusion line, stability when the device is dropped. You might want to evaluate this in the form of a matrix with a positive or negative comparison against your own product. Step 3 is to consider and even name specific sources of information. The MEDEV guidance suggests some resources you can consider. Regulatory authority databases, e.g., Swissmedic, BfRM, FDA. Clinical literature, e.g., via PubMed and Embase. Registers. Trade fair and product catalogs, or instructions for use. Technical databases, e.g., on material properties. Standards, regulatory guidance documents. Medical guidelines from professional societies. Information from manufacturers about faults, e.g., bug reports and release notes. Some post-market data, e.g., customer complaints, service reports, post-market clinical follow-up, or post-market performance follow-up for IVD's log files. And lab tests. Initially, manufacturers should look at each aspect of the key questions individually. At the end of this analysis, they should be able to answer the following questions. Is there any information that would allow conclusions to be drawn about this aspect? What alternative devices, technologies, and procedures exist? Which of them are better? Which are worse? And, does this information represent the state of the art, or the state of the science? Normally, the development of standards and guidelines takes several years. Therefore, they represent the state of the art rather than the state of the science. This analysis can now be used as the input for the clinical evaluation or performance evaluation, the risk management file, development, and the post-market surveillance plan. What is the state of the science today may soon be the state of the art, and obsolete not long after that, as other innovations are identified. That's why the regulations require manufacturers to update their analysis at regular intervals. For example, during the post-market clinical follow-up PMCF or for IVDs, the post-market performance follow-up, PMPF. In most cases the cycle should not be expected to be longer than 1 year. You might also feed this back into the risk evaluation and address it at the management review. The EU regulations make it unnecessarily difficult for manufacturers to meet the central requirements of these very regulations due to the absence of a definition of the term, the inconsistent use of the term state-of-the-art, and annoying translation errors. You need to consider the state-of-the-art within your technical evaluations and documentation to show evidence to the notified body, authorized representative, or regulatory authority. The state-of-the-art is not a constant. Manufacturers are obliged to define the state-of-the-art continually, usually at least annually. Manufacturers can fulfill this obligation as part of their post-market surveillance or post-market performance follow-ups for IVDs. We hope that you found this information useful. If you need further information or have any questions, or if you are looking for either an EU authorized representative or a UK responsible person, please don't hesitate to contact us.